So I want to just kick off our discussion about health equity data visualization. Two points to reinforce what we're doing. Number one is I believe firmly in the power of data visualization as a way to make points and to have impact. The reason we've been doing these visualization challenges and will continue to do so is because I believe data can be an important part of the story to be able to share messages about points that matter. And since our community is all about generating evidence, I think finding questions that matter and then providing impact of evidence by displaying that information importantly is critical to our success. And so for that reason, I want to thank Joel, Jake, Tony, Adam, and Jody-Ann for participating in this month's visualization challenge on health equity. And I would encourage all of you, as you're seeing the presentations, to take a look in the OHDSI Teams environment under OHDSI Viz Challenge July 2021 Health Equity to see what you're going to hear as a presentation. Just to orient you a little bit, a couple weeks ago, NPR had a story that was posted that was that they ran on the radio called "The Ripple Effects of a Huge Drop in Cancer Screenings." And during this 7-minute presentation, they talked about how there may be health equity issues associated with people who are not going back to get preventative screening. Now, you could listen to this, and it may or may not catch your attention when you're driving in the car on the radio. I was interested enough in the story, so I read the transcript of this thing, and it had some sort of an impact. It at least got me thinking, hey, I wonder if that's an interesting question, and I posted it onto the OHDSI Health Equity work group that Jake is leading. But ultimately, listening to something and reading a transcript of text doesn't necessarily have an impact. When I think about a data visualization, however, if I were to show you data from our OHDSI community about the proportion of women who get mammography at age 50 and look at disparities between whites and blacks, I can see quickly in data that there is tremendous disparities, that blacks have a lower proportion of mammogram use than whites. It has been happening consistently over time, and it is getting worse during the COVID time. This is one simple visualization that can actually show a pattern that doesn't require 7 minutes of listening to or 10 minutes of reading slowly through a transcript, but can actually convey an important message that could actually hope to promote people thinking critically about questions and issue. And so I share this because we have now leadership from our community, and Joel, Jake, Tony, Adam, and Jody-Ann, who have identified important visualizations that they're going to present to us. I hope that any of these will stimulate your thinking as it relates to health equity questions, as well as thinking about how data and visualizations can help advance understanding of those questions. So with that, Jake, would love to have you present your visualization and what critical insights you've gained from that.
Thanks. Craig, do you have it to pull up?
Yeah, so hold on. Why don't you start just, all right, let's see here. So I have,
yep, sure.
Yep, okay. Tell me if you see it.
Yeah, I do. Great. So I have 2 visualizations. So this is the first one, which probably could have been done better as a graph, but I think quickly what this shows is the year-over-year differences for different ages of total number of this was for cancer for cancer incidences, breast and lung and colon and prostate. And you would expect this, as the denominator decreases with age, that number would slowly decline. But what we do see in the data is a huge spike at age 65. You know, the theory for this is that 65 in the US is the age where people qualify for Medicare and will likely hold off on, or are probably holding off on screenings until that age. So this sort of maybe is showing lack of coverage and how that delays time to diagnosis of cancer. This is a visualization from the HERA data set. If you look at, there's a link in next to the visualization where you can go and pull up this graph and explore the data yourself. I annotated a few of the points here, and this is a comparison of Black versus white males aged 30 to 39 and the relative frequencies of different diagnoses. So you can see that that white males were much more likely to have a diagnosis of anxiety as opposed to Black males. And you can see the differences there. Some of these differences may be due to differences in treatment paths. Some of them may be due to differences in disease rates, and that's all stuff to entangle. But looking at these differences alone are quite interesting. And there's a lot of data on HERA, not just in these target groups, but yeah, it's a great thing to go and explore yourself.
Great, Jake. Thank you very much. Next up, we have Joel. Joel, are you good to go?
Yeah, I'm going to share my screen.
Okay.
Okay, I got my visualization from a paper called Intersectional Inequities in COVID-19 Mortality by Race, Ethnicity, and Education in the United States from January 20 to 21. And it's from a team from the Harvard Center for Population and Developmental Studies led by Chen. Just real quick, going through the methods, what they did was they got all the death certificates, all the death data from the National Center for Health Statistics. They gave all the death data stratified by race, ethnicity, and education. And just to point out, educational attainment is routinely reported. You can find that from death certificates, so that's kind of interesting. They analyzed all the COVID-19 deaths, over 400,000 of them from that period of time, and looked at it by race, ethnicity, and educational level. And and the educational level they broke down was less than high school graduate, some college graduate, and postgraduate degree. The denominators they got from the U.S. Census Bureau. That can for 18-year-old and over from 2020 with race and ethnic Hispanic origin. The first visualization I wanted to show was, I think we may have well heard that there were disparities, health disparities in the Black community and in Latinx community as far as COVID goes. This shows a little bit of that disparity. For non-Hispanic Blacks, there was about a 30% difference in the incident rate ratio compared to non-Hispanic whites. For Hispanics, there was about a 10% higher incident rate ratio. For Native Americans, it was particularly bad, 70% increase. And there was actually a protective effect in Asia Pacific folks in the United States, where there was a 40% protective lower rate of COVID mortality. But the one visualization I was particularly interested in was this one, where they stratified by education level. And the bars here represent different education levels, going from less than high school all the way to postgraduate degree. And what you see when you break it up, and then it's all by race, ethnicity, white, Black, Hispanic, Native American, Asia Pacific. What you see is kind of striking, what I thought, because the rates between whites and Blacks are now basically similar, except when they're stratified, you can see a very steep trend increasing in mortality rates based upon lower education level. So lower education level, the much higher rates of of mortality within these groups. And you can see between whites and Blacks, the different bars are about the same. And actually, for Hispanics, you see lower levels of lower rates in each of the groups and even compared to whites. The disproportionality comes in when Black and Hispanics are more likely to be in the lower educational level groups. The trends are actually worse in the Native American groups and better in the Pacific Islander groups. So just to say what this speaks to, just taking it from the paper, you get an excess mortality burden due to socioeconomic deprivation, as evidenced by the lower education levels. And the important thing is the risk of exposure to SARS-CoV-2 is greatest among those working in public-facing essential jobs, documented to be predominantly low-wage, precarious jobs with limited or no sick pay and disproportionately employing workers of color. So while it's nice to call these people superheroes, they've actually given their lives for for their jobs for us, so we could go to the supermarket and have our shelves stocked. Question I would have just for OHDSI, we need to make sure we take into account socioeconomic status in our analyses on health equity, and I guess maybe we'll be talking about that this afternoon at the health equity session. Thanks.
Great, Joel. Thank you so much. I'm going to change the order a little bit just because Adam got a chance to speak during the earlier portion. Tony, if you're there, do you want to go next? And then we'll go Jody-Ann and then Adam.
Sure. I'll share my screen. Open this up. Does everyone see the interactive visual?
Yeah, I can see it, Tony.
Sounds good. All right, so this is an interactive visualization that's shared on the Health Equity, as an HTML file on the Health Equity channel on Teams. It's a visualization that Noemi, Patrick, and I are working on that shows the time to diagnoses differences for the top 50 symptoms for each of these 124 heterophenotypes on the y-axis. So essentially, each of these little dots is a top 50 symptom that we've chosen for a particular cohort, say like HIV or hypertension. And essentially what we see is that the x-axis values are the time to diagnoses differences for the same symptom across women minus men. So a positive difference above 0 indicates that women are being diagnosed later with that particular presenting symptom. This data comes from patients with at least 3 years of healthcare observation data prior to their diagnosis. These are symptoms prior to their diagnosis and enter into like a particular cohort for, say, Crohn's disease. And what we see is across all 124 cohorts and for the vast majority of presenting symptoms as we've defined it, women are being diagnosed later with the same symptom. Which you can consider medians of all the symptoms, or if you just were to consider like the individual symptoms themselves. And so, yeah, these box plots summarize the individual symptoms. And for all but a few diseases, I think the only 2 examples where there's men being diagnosed later, it's HIV and cirrhosis. Women are being diagnosed later. And this is data that comes from CCAE, which is a private administrative claims database with like millions of patients. We are also working with Patrick and folks to have data from Medicaid, Medicare, and Columbia on our side. But yeah, it's just a very surprising finding that we hope to dig more into.
Great, Tony. Thank you for leading this. Obviously, great work coming out of the Harris study. Jody-Ann, do you want to go next?
Sure, I'll just share my screen. I'll just keep this very quick, very short in the interest of time. I wanted to share with you all the diagram that we've been using for, or we are going to be using for, a paper that we're writing about characterizing COVID-19 experience of Blacks and whites during the first 6 months of the pandemic. This is really just using data from Charybdis, which I know many of you all have worked on, so thank you. One of the things that really strike me about this is that, we are considering both variables that are easily accessible, easily quantifiable. So that's age, comorbidities, and how it relates to adverse outcomes, testing, diagnosis, hospitalization, and treatments. And also the ones that are not so easily quantifiable. For example, health-seeking behaviors, access to healthcare, exposure. These are things that we are not readily, might not be readily available in or data sets, but we can pull that out and can take a look at that. So this diagram here really represents one of our hypotheses about varying degrees of association. So for example, we know that age, comorbidities will really have a significant impact on, let's say, the outcomes of a patient or the severity of disease. But at the same time, comorbidities may also have a lesser impact on testing or on diagnosis. And those are represented by the thickness of the lines. One thing I really wanted to point out is that race, for example, may negatively be impacting health-seeking behaviors, right? And these are all things that we need to consider as we are doing our studies. And I think this diagram really does a good job of really putting all of that together. How both the variables that are easily quantifiable and the ones that are not so easily quantifiable might be playing a role in the impact and associations of risk factors and outcomes of patients. Thank you.
Great, Jody-Ann, thank you for that. Thank you for helping lead this paper or this study. Adam Black, you are returning to the main seat to provide our final one.
Okay, great. The visualization that I found, can you see my screen?
Yes, I can.
Okay, it's from this paper called Racial and Ethnic Disparities in Years of Potential Life Loss Attributable to COVID-19 in the US. So I just want to explain a little bit of background. Years of potential life lost is an alternative measure of mortality that explicitly weights deaths that occur at earlier ages more heavily than deaths that occur at later ages. So the formula is just using some reference age, the difference between a reference age and the age at death. So in this paper, they're using 75 as the reference age. And if someone dies over age 75, then YPLL is 0. So we want to compare YPLL between two populations, and one simple way we could do this would just be to add up the total YPLL for all of the people in that population. But then if one population is larger than the other, it's, you know, we don't get a fair comparison because YPLL is larger in that other population. So we can just divide by the population size and get a YPLL rate. And we can also then adjust for differences in the age structure of the population so that we can get a fair comparison between these two populations. So what we're doing in this visualization is comparing the years of potential life loss between non-Hispanic Black and non-Hispanic white. So non-Hispanic white's the denominator and non-Hispanic Black is the numerator. Another thing the authors did that I thought was really interesting was incorporating uncertainty. So there's 3 types of uncertainty they incorporated. One was interval censoring. So we don't actually know, this data is taken from National Health Statistics, so we don't actually know the exact age that someone died. We have an interval. There's also suppression when the death counts are low within an age interval. And for some deaths, we don't know the race, ethnicity of the person. So one thing that's not on this list is statistical variation and sampling variation. And so that's interesting since most methods are kind of focused on that. But here the authors had to use some interesting methods to deal with these three types of uncertainty. And they say that you should not interpret the center of this interval that they create as a point estimate, but just sort of look at the whole interval as like an uncertainty measure. So here's the picture. So we have the red line of 1. So that would be where the rate rate ratio between Black and white would be equal. And it immediately jumps out to me that most states, over half the states, are far to the right of that, meaning that for both mortality and YPLL, the Black rates are much higher than the white rates. For the overall U.S., just looking, and also YPL is much higher than mortality, so it's actually interesting to think about the difference not only in just mortality, but also at the age at which people are dying. which I think this highlights. In the U.S., it's around 3, and then also in Michigan, it's close to 6, which is just such a huge rate ratio. It's rare that you ever see an effect that large. So seeing a huge effect like that that's linked to race and ethnicity, potentially mediated by education differences, as Joel was pointing out, is a big deal. And then also kind of links back to action. So I found this Michigan had this task force on racial disparities, which kind of comes out of this realization. And I think these disparities have probably existed for a long time, but the COVID-19 kind of highlighted it and maybe caused some people to take some action on it. That's what I wanted to share.
Great, Adam. Thank you very much. We're at the end here. We have some great conversation going on in the chat. So if you were watching a lot of these presentations, you may want to go in the chat and learn a little bit more. But thank you again to Jake, to Joel, Tony, Jody-Ann, and Adam for your presentations. If you're more interested, remember the next Health Equity Workgroup meeting is at 2 p.m. today, 2 p.m. Eastern Time today. So please join that. Also, thank you to Martijn, Hina, and Adam again for the unit testathon talk earlier. All of these will be posted to the community call page later. And other than that, I hope everyone has a great week, and we'll see you next week for our APAC regional updates. So have a great week, everyone.